Hi everybody, my name is Judy Hoy and the purpose of this presentation is to provide education about sexual violence and intimate partner violence screening tools in the clinical setting. If you've not already taken the pretest survey, I ask that you do this before viewing this presentation. The CDC defines sexual violence as any sexual activity where consent is not freely given. Intimate partner violence can be defined as abuse or aggression that occurs in a close relationship, which can vary in frequency and severity and includes physical and sexual violence, stalking, and psychological aggression. The CDC reports that more than 1 in 3 women and nearly 1 in 4 men experience some form of sexual violence involving physical contact during their lifetime. Additionally, about 1 in 4 women and 1 in 10 men have suffered from some combination of IPV behaviors from an intimate partner in their lifetime. The National Intimate Partner and Sexual Violence Survey of 2010 to 2012 revealed that multiracial men and women report more experiences of both sexual violence and intimate partner violence than other races and ethnicities, with Asian Pacific Islander men and women reporting the least. Research shows that men and women ages 18 to 34 have a higher risk of experiencing sexual violence than other age groups. And the most likely age for both men and women to experience intimate partner violence for the first time is between the ages of 18 and 24. When it comes to sexual orientation, research shows that bisexual women are more likely to experience rape than lesbian or heterosexual women. For sexual violence other than rape, bisexual adults report more experiences than gay, lesbian, and heterosexual adults. We see the same trends with intimate partner violence, with bisexual men and women reporting more experiences than adults of other sexual orientations. The number of IPV occurrences varies between different income brackets. However, it is not isolated to any particular bracket. The health consequences of sexual violence and intimate partner violence can be severe and long-lasting. Some physical effects include injury from assault, somatic complaints, localized pain, and trouble sleeping. Mentally, a victim might experience depression, anxiety, suicidal thoughts, eating disorders, phobias, low self-esteem, PTSD, nightmares, and various negative emotional reactions. Sexual and reproductive effects for women include vaginal bleeding, unwanted pregnancy, STDs, miscarriages, UTIs, fistulas, painful sexual intercourse, and sexual dysfunction. Behavioral effects include difficulties with relationships, withdrawal or isolation, substance abuse, and engagement in risky sexual activity. Many of these consequences can turn into long-term issues for survivors. Additionally, long-term effects include, but are not limited to, asthma, irritable bowel syndrome, frequent headaches, chronic body pain, chronic pelvic pain and/or infection, and femicide and AIDS-related death. Additionally, sexual violence is connected to other forms of violence. For example, girls who have been sexually abused are more likely to experience additional sexual violence and other forms of violence and be a victim of intimate partner violence in adulthood. Although this presentation is focusing mainly on sexual violence and intimate partner violence, the Adverse Childhood Effects Study is a great example of the ways abuse can have lifelong damage. Adverse childhood events include experiences of physical, mental, and sexual abuse or neglect, violence in the home or community, having a family member who attempts or dies by suicide, or growing up in a household with substance abuse, mental illness, or parental relationship instability. The ACE study shows links between experiencing adverse childhood events and being diagnosed with comorbidities later in life, including ischemic heart disease, cancer, stroke, COPD, diabetes, hepatitis, and skeletal fractures. Based off the statistics I shared with you earlier, we know that victims of sexual violence and intimate partner violence tend to be women more often than men, multiracial more often than other races and ethnicities, younger rather than older, bisexual more than gay, lesbian, or straight, and can be from any income level. These statistics are important and can help bring awareness to populations who need it most. However, it is important for healthcare providers to remember that a person of any gender, race, age, or sexual orientation can have a history of victimization or a chance of victimization in the future. It's possible that a victim presents just like any non-victim would in the clinical setting. However, there are some behaviors that sexual violence victims might exhibit that should raise a red flag for providers. Some of these behaviors include delaying seeking medical treatment for injuries, complaints of nonspecific symptoms, and complaints of any of the previously mentioned health consequences. Behaviors of intimate partner violence victims might include inconsistent explanation of injuries, frequent emergency department visits, missed appointments, medication non-adherence, inappropriate affect, avoidance of eye contact, hostility, appearing socially isolated, reluctance to undress or have a genital, rectal, or oral examination, repeat abortions, late prenatal care and pregnancy, and being with an overly attentive or verbally abusive partner. In 2007, the CDC released a publication titled Intimate Partner Violence and Sexual Violence Victimization Assessment Instruments for Use in Healthcare Settings. This document outlines 34 screening tools for intimate partner violence and 14 screening tools for sexual violence, with some assessments being included in both sections. Among these screening tools were the HITS, Danger, and Victimization Assessment tools. The HITS assessment is a 5-item self-report or clinician-administered tool that assesses the frequency of intimate partner violence. HITS stands for Hurt, Insult, Threaten, and Scream. The Danger assessment is a self-report of 20 items and assesses a woman's potential risk of homicide by a male partner. The Victimization assessment tool is a 5-item clinician-administered screening that assesses physical intimate partner violence, sexual violence, suicidal ideation, and risk of hurting others. Additionally, though it is not included in the Intimate Partner Violence and Sexual Violence Instruments publication, the ACE and Resilience tool is another great screening. It consists of 2 portions. The ACE portion of the questionnaire includes 20 questions about various childhood trauma. The Resilience portion is 14 questions and reflects a person's ability to recover from or cope with trauma. Some benefits of implementing sexual violence and intimate partner violence screening tools in the clinical setting include identifying more victims and helping them sooner rather than later or not at all, preventing further or future abuse, and saving time and resources by discovering the possible source of patients' physical, mental, sexual, and behavioral health issues. I'm addressing potential barriers based off of what I found in the literature as well as the answers that you guys provided to me in your pre-surveys. One of the most prevalent barriers is time. Providers might feel that time is too limited to incorporate routine sexual violence or intimate partner violence screenings into visits. However, simply including a yes or no question in patients' intake paperwork like, "Do you feel safe?" could help save time by narrowing down which patients might need to be screened for violence, as research shows that many victims have a decreased sense of security. Privacy is another issue. A patient is less likely to report abuse or feeling unsafe if their abuser is with them during their visit. However, an overprotective or overattentive partner should raise a red flag to providers anyways, and an effort should be made to isolate the patient for at least a portion of the visit. Still, it is possible that the patient may not be honest when asked about occurrence of abuse. However, providing a patient an opportunity to share a history of victimization still increases chances of reporting compared to providing no opportunity at all. A provider may worry that inquiring about such topics could be triggering to a patient, or that the patient is simply not interested in sharing. This is very possible. However, a study done in 2007 at a family planning clinic in Texas with 945 female participants found that the majority of women were not bothered or upset about being screened for sexual assault, and that they actually found information about physical and emotional effects of unwanted sex and information about victims' resources helpful. If the screening process does trigger the patient, it is possible that both the patient and provider are now distracted from the initial reason for the client's visit. A solution to this is to incorporate screenings at the end of the visit. This way, providers could prioritize clients' initial concerns and still provide an opportunity for victims to share about experienced violence or trauma. Another barrier is providers' lack of knowledge about screening tools. A solution to this is for a clinic to choose 1 or 2 screening tools to use and have a quick information session with staff on how to properly use them. Many IPV and sexual violence screening tools are similar to depression and anxiety tools in that they include instructions and interpretation of results and are easy to use. With some patient populations, there is a risk for low health literacy. This can inhibit a client's ability to fill out screening tools. However, tools like HITS, danger, victimization, and ACE and resilience can be clinician administered for patients who have trouble with reading or comprehension. Providers may feel that they have a lack of power in actually helping improve the issue of violence victimization. However, simply providing information to victims about counseling services and hotlines could potentially save a life, or at least give them a safe space to ask questions. Lastly, providers might be unsure about whether their patient population is even at risk of being victims or suffering from consequences of violence. However, statistics prove that sexual violence and intimate partner violence is a prominent issue among women and men of all backgrounds, and that the potential health effects can be severe enough to impact victims physically, mentally, sexually, and spiritually, both short and long term. Trauma-informed care is described as a patient-centered approach to healthcare that calls on health professionals to provide care in a way that prevents re-traumatization of patients and staff. Providing TIC involves being aware and sensitive to a patient's needs, history, and feelings. It is implemented by communicating therapeutically throughout the entire healthcare visit. Some approaches include introduction of self and role, open and non-threatening verbal and non-verbal communication, communicating clear expectations and purposes, consent to use therapeutic touch, maintaining privacy, using plain language, and checking the patient's understanding, and providing TIC to patients regardless of history. I wanted to take a moment to thank you all for taking time out of your busy schedules to complete my surveys and to view this presentation. I hope that you all learned something new, and at the very least, maybe it sparked a conversation, even if it was just within yourself, about the potential benefits of using these types of screening tools in a clinical setting like Victory. That is the end of my presentation, so if you guys could please return to the email and click the link to complete the post survey. Thanks.